All right. Thanks very much, Sophie. And I apologize if we don't get to everybody's question. We're going to try and get to as many as possible. And we'll try and some will be sort of grouped in all together. So we're just going to go back and forth between us. And thanks for giving us all these questions. There's a lot of excellent questions. There were a couple questions about late onset MS. I particularly have had a lot of discussions over the last few years about people getting older with MS, with the assumption that people have had MS for a long time. But it turns out over the age of 50, about a total of 8% of people, maybe even up to 10% of people are diagnosed with symptoms starting after age 50. So while we think of this as primarily sort of a young adult onset, there's plenty of people who are actually younger, about 5% are pediatric MS under the age of 18, and about 10% or so over age 50, and about less than 1% over age 60 with onset of symptoms. A lot of times people get diagnosed in their 50s or 60s, but they actually had symptoms back in their 20s, 30s, 40s. That is not the same thing we're talking about. Why do we care? It's a mostly understudied area in MS. Do we sort of think about it as people who just sort of everything frame shifts, further down the road, if you will? I've already mentioned that the disease duration is perhaps one particular important component in response to therapy. And so it's not just age, it's disease duration. And so what the studies show is that late onset MS is more likely to have primary progressive MS from the outset. It's closer to a 50-50 male-female sex ratio. For those especially who have progressive MS from the outset, there's a more rapid accumulation of disability. Of course, you're starting at a later age, so you reach MS disability milestones older than, say, pediatric onset. But the reality is it's sort of a variation on a theme. The important question is, if you have run-of-the-mill relapsing MS and you are diagnosed at age 55, say, should you be treated? And the answer usually is yes. There's not a lot of data on this. It mostly comes from databases. Most of the people who have been in the studies have been excluded if they were over the age of 55. So we don't even have data for people who are 55 and were diagnosed when they were 35. We definitely don't have it for people who are diagnosed at 55. But from databases and from just personal experience, it looks like you would probably do just as well to be treated if you have a relapsing form of MS and typical active lesions on your skin and everything else. We would normally treat you, and the question still would be begged, how long would you do that for? And that remains to be seen.
All right. Well, thank you. I'm going to try to tackle 3 questions in one, since there's some overlap here. So the questions ask, how long does this type of chemotherapy last after or when you get that first stem cell transplant? What does that event time map look like when you get a stem cell transplant? And do patients receive any prophylactic antibiotics either before or after high dose chemo? So when someone is being evaluated for an autologous hematopoietic stem cell transplant, they will get a medication, like I said, to push kind of those immune cells out of the bone marrow. And then that collection takes place, I think it's like 24 or 48 hours later. So you can think of it as week 1 as collection, week 2 as initiating that high dose chemotherapy to essentially wipe out the immune system. And then once that is achieved, patients will get, usually it is a week or 2 where they'll get their reinfusion once the immune system is wiped out. But that lasting effect of chemotherapy, or sorry, no, actually that's 30 days. So they will get their stem cells back in 30 days. So basically think about it as a month of severe immune suppression. Patients are staying in the hospital during that time. Yes, you are getting prophylactic antibiotics. You're getting prophylactic antivirals, and your blood counts will be carefully monitored over that time. They monitor things very, very closely, really for 90 days. After 90 days, you're kind of outside of that critical window.
All right, perfect. There are a couple questions around sort of the issue of what about alternative approaches to treating MS not involving pharmacotherapy. And so one question was, what are the latest treatment recommendations for benign MS? And another one was, what does research say about MS progression to those who choose not to use disease-modifying therapies? Can MS be treated holistically? And what this gets at is, what is the role of other therapeutic approaches that are not pharmacologic? And how do you utilize that when you're making treatment decisions, especially early on, someone is newly diagnosed, say they're 35 years of age? And so a couple things I think are true. Number one, the best data in general, for treating especially relapsing forms of MS is with the pharmacologic therapies. That is by no means to say that there's not data. And in fact, at the summit in the fall, I talked a great deal about all the other therapies that are not pharmacologic. There's a great deal of data about that, but the data in general is less strong just in terms of the randomized controlled trials and things like that. But overall, the greatest impact that we have is from the disease-modifying therapies that have been proven pharmacologically, and then used in conjunction with exercise, not smoking, staying as close to your ideal body weight as possible, taking vitamin D. All those things do matter, but it's really in conjunction with the disease-modifying therapies. When someone is making a decision, when they're newly diagnosed, we do not know if they're going to have benign MS or severe MS. And there is a question also about, well, how do we define malignant? There's no good definition of malignant, but it's sort of like the Supreme Court said with pornography, we know it when we see it. But we're not smart enough to say when someone's newly diagnosed after a single attack exactly what's going to happen. So we're making a lot of our decisions before we have that. So the concept of benign MS is a post hoc determination. We don't make that when someone's newly diagnosed. So we're making decisions about treatment or not based on that. And so at the other end of the question, if someone has decided that they want to consider a trial off, that's fine. But the question about what does research say about MS progression to those who choose not to use disease-modifying therapy, when you're making those decisions early, what the studies show is very, very clear. People who, on average, if they do not get treated, do worse. That is just a simple reality. And that's the issue. The issue is we're making the decision before we know what's going to exactly happen. And so, but when those have been done, it is quite clear, or if you look at even just placebo-controlled trials where people got delayed in treatment for 2 years and then got put on the medication, it is quite clear that the outcomes are worse and you just don't catch up. You have a lifetime beyond that of worse disability because of the missed opportunity, which is why we're so focused on getting people on therapy early. It's not perfect. These drugs are not perfect. They have side effects. They have risks. There are all sorts of things to deal with, but that is what the data shows.
All right. This is more of a practical question. What hurdles do patients run into trying to get a stem cell transplant? Questions about insurance, lack of trusted providers. I think it's important to be clear that stem cell transplant, especially autologous stem cell transplant, which I discussed, is not something that we do as what we would consider standard of care. So everything that is being done with stem cell transplant is in the confines of a clinical trial. The reason that is we are still trying to figure out what is truly best for patients. There is a difficult, from a patient perspective, it can be difficult to get into those clinical trials because every clinical trial is designed with specific inclusion-exclusion criteria. So one must meet those criteria in order to be enrolled. With the BEAT MS study that I talked about looking at autologous stem cell transplant in patients with MS, it is a randomized controlled trial. So you can't choose what you're going to get. It is randomized, whether or not you get that, and I shouldn't have said controlled, but randomized, whether or not you get the transplant or you get the highly efficacious therapy. Now, once you are at that stage where you pass in terms of the criteria, you get randomized. Insurance actually does play a role. So even though I said this is not being done as standard of care, insurance has to play along to help with the ability to do the transplant in terms of cost and covering some of those procedures. So I agree from a patient perspective, it's not easy.
All right. There are several questions about disco and disco MS, sorry, and maybe not disco dancing. And that's later in the next section with those guys. But having to do with, is there like an algorithm? Is there a certain age? Is there a certain disease duration or anything else that has to do with when you would consider this, either a de-escalation or a discontinuation? There's no formal algorithm. But I did refer to the Swiss study where they looked at the 3 different factors: age, recency of an MRI scan, abnormality on your scan, and then also time since last relapse. They can sort of give you a reasonably good idea as to what that is. When someone has done a meta-analysis of all the different observational studies, not the randomized control trials that I mentioned, but all the observational studies, suggestion was by age 60 to 62, the risk of new disease activity for the average patient was pretty low and a consideration could be made. But as I just mentioned a moment ago, if you have late onset MS, that may not be true. So it's not just age, it's disease duration, both longer is better. It's recency of new activity either on a scan or with an MRI scan. And maybe it also has to do with the nature of the medication that you're on that play a role. And they all play a role, not just age. So there's not one single age, it's all those different factors. And related question came in, does progressive cognitive dysfunction play a role in terms of making those kinds of decisions? We think that progression of cognitive impairment is similar to progression of walking impairment or any other kind of impairment, bowel and bladder impairment. It's an important part, in fact, arguably the most important part of potential MS complications as people age. And so 2 things about it. One, MS unfortunately does not protect you against things like Alzheimer's and other things. So if there's a significant cognitive impairment as you age, especially if it's new compared to before, that's something that really needs to be addressed. And 2, we just view it as progression of MS without relapses and scan changes, if that is indeed the case. And so unfortunately, there's no benefit that persists with the medications. And in DISCO and in the DOT-MS study, we did look at least one cognitive test called the symbol digit modality test. And people who stayed on drug compared to people who went off drug, there was no differences in the changes in people's cognition during the course of the 2 years of the study, or actually into the extension as well. So unfortunately, staying on the medications in that context does not do anything to change any cognitive impairment.
All right, 2 pretty straightforward, quick questions here. Does the Cartt study require chemo? Cartt therapy is not the same as the stem cell transplant. You don't get that chemotherapy conditioning regimen. It is just that T cell that you're given back that is genetically engineered. And then another quick question, would you use anti-rejection medication for allogeneic stem cell transplant? Yes, you are getting donor cells. There is a difference in terms of after the transplant, what you need to stay on in terms of anti-rejection and a mild to moderate amount of immune therapy afterwards. That is different from the autologous.
All right, I have a couple of quick questions too, and this relates to the way that the DISCO MS study and some of the other studies that have been done. And one question related to when you say there's been a relapse, is there a standardized way that people sort of call the relapse? And the answer is yes. And this is a non-trivial question. It's actually very important because you could call a relapse one thing or another by different criteria, number one, but also when you're looking at large database studies, and there are some of these database studies that have up to 60,000+ people in the like MS base, for example, and they may have literally thousands of investigators putting what they call a relapse into a database, and then everyone just assumes that it's relapse, when in fact it could have been a pseudo relapse. It could have been somebody stumbled and broke their ankle and didn't walk that well when they got tested. I mean, it could have been 1,000 different things. And so it is a non-trivial question as to how you count. When you do it in a randomized controlled trial, it's very specific and everyone's supposed to follow the same rules. There's often a committee that adjudicates the relapse to say, yes, it was or no, it wasn't. And they're, blinded except to that, information. So it is important how you do that. And you use very rigorous criteria. Similarly, when we talk about new MRI scan changes, is that brain and spinal cord, or is it typically just brain? For most studies, it is just brain for a variety of reasons, because you're looking for, number one, asymptomatic activity, and there's a lot of asymptomatic activity that may occur in the brain but does not occur in the spine typically. But also, just from a functional point of view, you would end up adding 200% to the cost of the MRI scans if we included the cervical and the thoracic spine in every single study, every single 3 months or 6 months or 12-month visit, which would astronomically increase the cost of the study. So practically speaking, we don't learn that much more with including the spine if someone is asymptomatic. That is, if you have a new lesion in your spine, you're much more likely to have symptoms, and the patient's going to report it, and you're going to count it as a relapse anyway. So yes, those things matter. How you do it, how you count stuff, absolutely matters. And that's one of the reasons why randomized controlled trials are superior to just observational data.
All right, I think we still got time here. So two people asked this in slightly different ways, but if you have a stem cell transplant, can you go on to being treated with disease modifying therapy afterwards, particularly if it failed? There is no, that the whole point of doing the stem cell transplant is hopefully to not need disease modifying therapy. If someone is unfortunate enough that they develop relapse afterwards. And again, defining what that relapse looks like is going to be important. I'm not talking about progression. I'm not talking about lingering symptoms. But if someone is having evidence of inflammation, enhancement on their brain MRI or spinal cord MRIs, it would be reasonable. Obviously, the inflammation's there, it failed, to put someone on a disease modifying therapy at that point. But it's going to have to be a conversation with your neurologist, because you got that big load of chemo and because you got those medications, what is really the safest pathway at that point. So it's going to be a little dependent on the individual. I had experience with a patient, and this is years ago when I was a fellow. So perhaps maybe I have learned since then in terms of missing information. But this patient did get a stem cell transplant. She came back to our clinic, and unfortunately, right after pregnancy, she had 20 to 30 enhancing lesions. So that was a severe case that absolutely warranted putting someone on a medication at that time. But, everyone's going to be a little bit different, and that is an extreme that I described. And again, I was a fellow. She got the transplant out of state. I can't tell you what her conditioning regimen was because that was a decade ago now, almost. So.
All right. I have a couple of questions, specific small questions about anti-CD20 therapies, B-cell depleting therapies, same concept. And one question is, are upper respiratory tract infections as common with Ocrevus as they are with rituximab? I've not seen any direct head-to-head comparisons except for observational studies, and they look about the same. It is quite clear that infections in general are higher. Infections that are serious infections are higher, and the most common are actually upper respiratory tract infections as well as UTI. So it's sort of wind, wound, and water are the ones we care about, especially as people get more disabled. Wind is upper respiratory lung, wound is skin infections, and water is bladder infections. So very common, and they can either be more common, more severe, more persistent, or require multiple rounds of antibiotics, all of which make them more challenging. Other risks related to the use of these medications are the risks of vaccine response. We know that vaccine response is diminished with a couple of different classes that we use, the depleting agents like the B-cell therapies, rituximab and ocrelizumab, Ocrevus. but also with Gilenya in that class. That's Gilenya, Mayzent, Zeposia, and also Ponvory. And you have, in this case, a diminished antibody response to the vaccine. There are still other types of vaccine responses, T-cell responses, and actually Dr. Piquet probably knows more about this than I do, that are actually quite intact. If anything, there's a couple studies to show with rituximab, ocrelizumab, they're actually even enhanced with regard to COVID vaccination, for example. So vaccine response is complicated, and it appears that the only part that's affected is the antibody response. But it is reduced, and we know that the further you are away from your infusion, the better the response, especially if you give it 2 to 4 weeks before your next infusion. And so that is in part one of the benefits that we receive when we extend the dosing. We de-escalate by extending the dosing to, say, 12 months. Then you have a much more vigorous response with your antibodies, and you would, in theory, have a longer period of time throughout the course of the year where you had better control of infections, because there is a relationship, as I showed in one of the slides, between having recency of the actual infusion and risk of the infections. So there are benefits to de-escalating, and that's what we're looking for.
All right.
I got a couple here if you want,
Yeah.
about reversing damage. Those wings up there, you might want to do those.
Yeah.
Or minor repairs.
Myelin repair, yeah.
Yeah.
So there's a couple different questions, and I'll try to capture it in one. But will stem cell transplant reverse nerve damage or brain lesions? So I do want to make it clear what I talked about with the autologous as well as allogeneic stem cell transplants. Really, unfortunately, the goal of those is to change that immune system so you don't have ongoing inflammatory disease. These are not regenerative stem cell treatments. That's not captured in the studies that I talked about. That is in its infancy in terms of research, where we're not using those stem cells to reverse the nerve damage. So I tell patients really doing these therapies, what my expectations are is that we stop the disease, halt the disease, meaning no more progression, no more lesions, no more relapses, but not necessarily reversing the damage that has been done through the years. And that gets to the point, and when I presented the historical data, that is why the patients with progressive disease did not fare as well.
So if I could amplify that a little bit, as Dr. Piquet alluded to, regenerative therapies are in their infancy, and there are at least 4 studies that have done phase 1 and or phase 2 trials looking at using neural precursor cells, or what we would think of as neural stem cells, not bone marrow derived, but those that have already transitioned to go down a lineage where they can really only become nervous system cells. Because every stem cell, perfect stem cells, a fertilized egg, it can become an entire human being. But you have hair, skin, kidneys, lungs, livers, you have all these different organs. So they've all traveled down different lineages where they change, sometimes they drop out and other things happen. But at some point they're on a path where they're just going to become one thing, like a kidney cell. So for those cells, these neural precursor cells, the theory could be that you might be able to regenerate nervous system tissue in the brain and the spine by giving these neural precursor cells that would do one of 2 things. They would either just simply replace damaged cells. You presumably would, once you get them, there's several ways to get them, but once you get them, either inject them into the spinal fluid in your lower back, or the most recent study was through a port in the top of the brain where you inject down into the ventricles of the brain. It's actually, I know it sounds more invasive, but it actually is easier to do repetitive testing and repetitive injections of the cells. And the hope would be either you would just replace the cells that were damaged, or more importantly, more likely, is that you would actually produce some kind of growth factors that would then stimulate the cells that are already in your brain and spine, which are capable of becoming fully differentiated and repairing, but have been somehow limited. And there's a whole field of trying to understand what are the limitations to neural outgrowth so that the cells, the neurons can actually grow nerve, or to remyelinate. And so understanding those basic processes first is important, but then being able to unleash the possibilities of regeneration, that's in a big picture sense and in a science fiction sense maybe, is where the money is, because that's where the greatest unmet need is in reversing disability. And that's where we'd really like to see stuff happen, but we're early. And I think we're late. It's 46 right now. So thank you very much for all your questions. We apologize if we didn't get to them, but you're going to have a little bit more time later on. We're going to leave this list with those guys too, and if we have some opportunities, they might be able to get to some also. So thanks for your attention.